Dr. Badano will now present how to assess patients with heart transplantation using echocardiography. He will allude how to measure the left ventricular dimensions. He will also look at the right ventricular dimensions and then look at Doppler echocardiography. Finally, he will also deal with all the potential complications related to this kind of patients.
The first and one of the most important steps when you are going to study a patient with a previous heart transplant is to look at the results of previous examination and possibly at the images of the previous examination. This is before there is no normal or physiological heart transplant physiology. Each patient is different from any other, and they can act just as a control of themselves. So the point is that every measure, every image that you can acquire during the present study should be compared with the previous one to be able to say, okay, this heart transplant patient is going well or is going to have a suspicion of a complication such as acute rejection on or CAV. Then when you have become confident with the previous physiology of the transplant heart in this patient, you can start your examination. Usually I start with the long axis view, and from this view I try to get an overall impression of the left ventricular function, but also very important is to look at the presence of a pericardial effusion at the thickness of the interventricular septum and the inferolateral wall. This can be done just freezing your image on an diastolic frame, and then you start measuring directly on the 2D images, and you measure the thickness of the interventricular septum using the leading edge technique like this one, and then the thickness of the posterior wall. This is really important because this measure, when compared to the previous one, tells you if there is any thickening of left ventricular walls. That is one of the first hints that an acute rejection may occur. Or you can do even a better job when you use the M mode to measure the thickness, because the temporal resolution is higher. Usually it's quite difficult using conventional M-mode technology to have a perfect alignment and a perpendicular alignment of the M-mode beam to the direction of the interventricular septum and the inferolateral wall. Another way to have accurate measurements of the thickness of left ventricular walls is to use the anatomical M mode. This will allow us to avoid the limitation of conventional M mode, that it's very difficult to align perpendicular to the direction of the interventricular septum and the inferolateral wall. The anatomical mode allows you to redirect both the direction and the position of the M mode beam in order on 2D images that have been already acquired, and then when you are ready and well aligned, you can just stop your running your movie and you can start the measurement. And here is really easy because you measure as any usual M mode, leading edge to leading edge. This is the septum. Then you have the diameter of the left ventricle and then the thickness of the posterior wall. And these measurements are one of the most important during the examination of the patient. When done, I go on looking with the color at the function of the heart valve. Here you see a trivial aortic regurgitation that was already existent immediately after the transplant, so it's not a big issue here. And then I move my color sector on the mitral valve, and again there is a small mitral regurgitation. and the detection of mitral regurgitation and comparison with the present color, jet, and the severity with the previous one is again another important step during the examination of the cardiac heart transplant patient, because worsening or appearance of a new mitral regurgitation or a worsening of a previous one is one of the signs of the occurrence of the acute rejection. Then I move my probe, rotating by 90 degrees, to start acquiring short axis view. The first one is on the basal part of the heart, looking at the aorta, the aortic valve. Then I put the color in order to check if the origin and the actual size of the small aortic regurgitation. Then I tilt a little bit heat to move the color on the pulmonary valve, and again I detect a small pulmonary regurgitation that was already present here. Then I go and look in detail at the pulmonary artery. This should be done particularly when there is a recent heart transplant, to look at the suture line of the pulmonary artery if there is any leakage or any stenosis. This is a quite rare complication, but it may occur, and the first examination immediately after heart transplant should look at the suture at the pulmonary artery as well as those to the aorta. Then I go down, tilting the probe again, looking at the left ventricle at the level of the mitral valve, and then I tilt a little bit with the color to check the origin and the extent of the mitral regurgitation. And then I come back to the longer axis view at the basal part in order to look at the inflow of the right ventricle. Here you see the patient has a pacemaker wire that is this highly reflective echo, linear echo here, crossing the tricuspid valve. This is the right atrium, and what I have to look here is at the position of the wire within the tricuspid valve, and also at the presence and the severity of tricuspid regurgitation. Tricuspid regurgitation is quite common in patients, particularly with those with old heart transplants, since it is quite a common complication of the frequent endomyocardial biopsies that these patients underwent during their follow-up visits. So it's particularly important to look at the severity of the regurgitation, and again to compare what you are seeing at the present examination with the images of the previous one. Not only the tricuspid regurgitation should be checked in terms of color to look at the complications of biopsies, but also it is very useful with the continuous wave to sample the tricuspid regurgitant jet to obtain the maximum gradient between the right atrium and the right ventricle to derive the pressure in the pulmonary artery. This is, again, an important parameter to monitor. Usually it's a little bit higher immediately after the transplant, when the body and the heart is adapting to the previous dysfunctioning heart. Usually it declines during the first months after transplants and then stabilizes unless there is any complication, and usually the complication is the dysfunction of the left heart. Then I go back on my short axis view at the level of the left ventricle to have an overview of the global ventricular function. And you see here it's quite a good left ventricle in this patient. Then we move our probe from the optical approach to start acquiring images from the apex. This is the usual appearance of the heart transplant in a patient in which the heart has been transplanted using the sieuamtim technique, which is the roof of both the atria are those of the patient, and half of the atria and the rest of the heart are the donor heart. This is explained these huge atria that are typical of the heart transplant performed with this technique, and also the presence of these shooter lines that shows you the region where the native atria have been sutured to the acquired ones. And also the four-chamber view provides us an overview of the left ventricular function and the right ventricular function. Then you can turn on your color modality to check again the regurgitations. And then you put the sample volume of your pulse Doppler at the tip of the mitral leaflets to record the pulse Doppler of the mitral inflow. Usually, patients with previous heart transplant have a pattern that is a restrictive one. The E wave is much taller than the A wave. The deceleration time is really brief. This type of left ventricular filling would be pathologic in a normal patient, but this is quite usual in heart transplant patient. And again, it's really important to measure these velocities and to compare the velocities of the E and the A wave and their relation with that has been quantified during the previous examination to see if there is any worsening of the filling and so the diastolic function of the transplanted heart. Some studies have shown that there is a high sensibility of the changes in the filling pattern of the left ventricle to detect the acute rejection of the transplanted heart, but indeed this has not been confirmed. They are too load dependent to be a real thing. But however, it's very important to be detected. Even more important, if you can relate the pattern, the Doppler pattern of the inflow to the TDI of the myocardium, both at the septum and in the lateral wall. And this is usually done turning on the tissue Doppler imaging modality and then sampling with your pulse Doppler first up the septum and then at the lateral wall. And then you make the ratio between the E wave measured on the pulse, the transmitral Doppler, and the average of the E prime velocities taken at the septum and the lateral wall. Doing that, I will go on looking at the function of the left first and then the right ventricle. And here is the left ventricle that has been magnified by reducing the depth of the acquisition in order to look at the global and the regional function. You immediately realize that here there is a dysynchrony of contraction. There is a thickening of this part of the heart, but it is dysynchronous, and this is due to the paced rhythm in this patient. So you record the four-chamber view, and then the two-chamber view, and finally the long axis view in order to have an overview of the global left ventricular function and also the regional one. And then you take your four-chamber view and the two-chamber view to measure the volumes and the ejection fraction. So the four-chamber view, you stop it, and then you go for the end diastolic frame. Here is quite difficult because it's a pace rhythm, so more than the ECG, I look at the mechanics of the left ventricle, and then you turn on your screen. You select for volume, biplane. The biplane disc summation algorithm is the recommended one in everyone, but particularly in these patients with in whom the shape of the ventricle is not always regular. And then you trace the endocardium as you usually do, to obtain the volumes and the ejection fraction in this heart. You do it in diastole, and then, like I have done, then you do in systole in both the 4-chamber and the 2-chamber view. Then you move, you tilt a little bit your probe to look at the right heart. Here is a dedicated, a focused view for the right ventricle, so I don't care anymore so much of the left ventricle, just concentrating on the right one to look at the size and at the motion. And here I realized that there is some dysfunction of the right heart. Again, this may be not an issue if it was already before like this, but it may be a real issue if it is a new finding during this particular examination. It's not very useful in patients with heart transplant to measure the TAPSE. This is usually done routinely, but as any other patient with the previous cardiac surgery, the TAPSE is quite misleading. It can be abnormal even if the systolic function of the right ventricle is normal. In this case, despite the TAPSE, I realized that the transversal function of the right ventricle is impaired, and the right ventricle seems to be quite enlarged. From this view, I check again the velocity through the regurgitant jet through the tricuspid valve to have another measurement of the gradient between the right ventricle and the right atrium. And then you can look at the TAPSE that is reduced, but as I said, it's not so important. But if you don't have a 3-dimensional echo to measure volumes and ejection fraction of the right ventricle, you can measure the fractional area change. Again, I will first select the largest area of the right ventricle. Then you go on the area and then make the planimetry of the area of the right ventricle, first at the largest, that should be the end diastolic frame, and then at the end systolic frame, in this way to get an index of a right ventricular pump function. Then it may be useful in patients, particularly in patients with heart transplant, if there is anything changed from a previous examination, to look also at the diastolic function of the right ventricle, just sampling the inflow of the right ventricle, and as I did now. We have seen that there is a tricuspid regurgitation. There is a pacemaker crossing the tricuspid valve. So one of the questions is the origin of the tricuspid regurgitation. This is not a main issue in this patient because the tricuspid regurgitation was really mild, but sometimes you have a moderate or also severe regurgitation, and you are wondering which is the cause of the regurgitation. If there is no trauma on the tricuspid valve due to biopsies or the other issues related to the surgery, one of the causes may be the interference of the pacemaker catheter with the tricuspid leaflets. And this is something that you can easily check with your 3D scanner. You change your probe, moving to the 4D. make the acquisition from the apex, and then you can easily check the position of the catheter in the tricuspid valve by rotating your 3D dataset as I am doing now. And then you see that you can identify this highly reflective echo that is the position of the pacemaker catheter that is in the commissure between the septal and the posterior leaflet of the tricuspid valve, so it's in a correct position and it's not interfering with the motion of the leaflets as it may occur. Then your 3D echo probe allows you also to have a more accurate measurements of the actual size of the left ventricle. You can use it as a multi-plane probe that will allow you to acquire in the same heartbeat all three views, the 4-chamber view, the 2-chamber view, and the long axis. This is particularly useful in patients who are in atrial fibrillation or with the irregular rhythm, where it's quite difficult to obtain 4-chamber and 2-chamber views at the same heart rate. And also measuring the volumes and ejection fraction using the triplane is also much more close to the actual function, because it allows you also to take into account of the contribution of the anterior septum and the inferolateral wall to the overall left ventricular function. Then, if the patient is cooperative and have a stable heart rhythm, like in this patient in which the rhythm is spaced, you can make the acquisition of the full volume of the left ventricle and the right ventricle, and having, first of all, an overall assessment of regional left ventricular dysfunction as well as a global left ventricular dysfunction. However good has been your examination, however careful have been your measurements, I recommend again not to take what you have measured in this single examination as details to judge about the overall function of this transplanted heart. All the measurements and details that you have detected should be compared with those that have been detected in a previous examination of the same patient.
So, as you have seen, there is no normal patients and a lot of variability between patients to patients. So the main point is indeed to take into account the previous examination to compare with the present one.